Joint replacement has been around for probably 50 years, 60 years, 70 years. It's been a long time. And if you think of something that we have done as orthopedic surgeons that have benefited mankind the most, it would be joint replacement. I can remember my grandfather, and he would spend summers with me and my dad and our family. And I can remember he would sit in a rocking chair or a lawn chair in our front yard. He would not move. You know, and the reason he couldn't move is because his hips were so bad. Because I can remember watching him waddle back and forth, not knowing at that time what was wrong, but that's what was wrong with him. And so now, over the last 50 years, we've developed joint replacements. Total knees, total hips. Shoulders have come on strong maybe in the last 10 to 15 years. But really, those procedures really are the most gratifying thing to people, and we're pretty good at these. So now, before we get started, we're gonna pass an offering plate here to take up some money for this talk. So we'll start in the back there. But how many people have had a joint replacement? Okay. How many need a joint replacement? Okay. I'm glad, because we're going to do something different tonight. We're going to actually have a live demonstration. So if we could have a volunteer here. Okay. And we're going to go in the back, and then we're going to, you know, they said take a tour. Well, we're going to watch you. Okay. So in the 30 years that I've been doing this, it's really, really interesting that you can reflect back on what's gone on in joint replacement over that 30 years. I trained at, it used to be called Milwaukee County Hospital down in Milwaukee. And I've had 2 sons go through that program, and now it's called the Medical College of Wisconsin. But I can remember watching a knee replacement by Roger Johnson, who is a wonderful surgeon, and he didn't have any guides at all. He did this all freehand. And it was amazing. And then when you're on his rotation, you need to do this. Well, you couldn't do what he was doing. And then we brought in different jigs, and then we've progressed. And so tonight, what I'm going to do is share with you what I think are 2 of the neatest things in joint replacement. And not everyone does this. It's not that I'm special. I've just gravitated toward those areas. But I'm going to show you some of this stuff, which is going to just blow you away. I will guarantee you. So the first thing we're going to do is talk about hip replacement. The history of hip replacement is that, again, it's 50 years old. And when we started doing this, it was made out of stainless steel, and it was made out of plastic. And the limiting factor in that procedure was that the plastic would wear out or the hip would dislocate. And the dislocation rates were a function of the radius of the ball that we would use in that femoral component. So if you had a small ball, then it would dislocate rather than a larger ball, okay? And at that time, we had really, really thick plastic, thinking the thicker it was, it wouldn't wear out as much. So now let's fast forward, okay? Then we went into metal on metal. And so we could get very large metal balls that wouldn't dislocate, but then we ran into some wear and tear problems with metal particles. And now the lawyers got a hold of it, and so now we've stopped doing that. So probably over the last 5 or 6 years, the in vogue thing is now anterior approach total hip replacement. Has anyone heard of that? Has anyone heard of that? Yes. When I trained 30 years ago, we would do it through the back. And it's called a posterior approach, okay? And now we've developed this so that if we protect the structures in the butt, then the prosthesis, which tends to be dislocated backwards, doesn't do that as much. So if we go through the front, and that's called an anterior approach, then we protect all the structures in the back and it doesn't dislocate as much. And we're able to do some other things. So that's what we're going to first talk about. And then we'll ask and answer a lot of questions. Most of the time will be spent going back and forth like this, okay? And then I'm going to talk about knee replacement and some of the neat things that we do with that, okay? So, just really, really briefly. So as we look at the anatomy, we have the ball and the cup. We call this the femoral head. We call that the femoral shaft. And this is your pelvis. And the cup portion, we give a name to it, called it acetabulum. And then the ball is the femoral head. And then people who have hip problems are going to have some of these things. You know, they're going to have joint swelling, they're going to have stiffness. Now in the hip, you can't really appreciate swelling. Now, I personally have had both my hips replaced. 5 months ago, I had my first one. 3 months ago, I had my second one. So if I'd say, what is the most common symptom? I'd have to say pain was standing. I mean, I could hardly stand while I was doing surgery. And the other thing is, once you get up out of a chair, you cannot go right away. You're standing, right? And then you have to wait around, and then you can go. You don't want to embarrass yourself, right? Am I right?
You are.
And that's a very, very, very common thing.
I thought that was just old age.
That was old age? Well, it's part of hip problems too. But still, I mean, that's a very common thing, okay? And so I would add that to the list. And so if we look at x-rays, we look at a normal hip over here. Here's the ball, here's the cup. And this space is not a space, but it's articular cartilage that doesn't show up on an x-ray. And if it doesn't show up on an x-ray, it looks like a space. So when you have space, that means you have a lot of articular cartilage, you don't have arthritis. This side, there is no space, and so we call this bone on bone, and we do not have any articular cartilage, and this person has a lot of pain. They cannot tie their shoes, right? They can't tie their shoes. They have this problem with, pardon me?
It's with a lot of difficulty.
With a lot of difficulty. And that's why we use Velcro shoes now, right? No?
I can't do that either.
Yeah. Can't do that either? Okay. You know, she's barefoot. Oh, okay. So we have bone on bone. And so then we made this decision. Let's say that you want to or you need to have hip replacement. My decision was made because I could not do the things I like to do. Believe it or not, I could not swim. You know, Fred used to be the YMCA director, okay, YMCA. And so we would swim every day for 25 years. And Fred remembers in retrospect me saying, in the sauna, while we had a towel around each other, or I should say around ourselves, but you can remember me saying, my hip hurt. And this was probably 5, 6, 7, 8, 9, 10 years ago, but I could not swim, I could not do surgery very well because I just could not stand that long. And really it's going to be up to you as far as what you like to do and what you can't do. And that's really the decision maker. So what we really want to focus on is we're going to assume that you're going to have a hip replacement. And now let me just try to tell you the difference between the traditional way that we used to do it and then the more, I don't know, it's the more progressive way. 20% of the orthopedic surgeons do anterior hip approach. 80% still do posterior. It's not right or wrong. I used to do the posterior approach for 25 years. Now that I do it anteriorly, I love doing it that way and people do respond. I had both of my hips done anteriorly. I went home the same day from Chicago. Okay? So I'm telling you what I did. It's not right or wrong, but I think it's better. So as we look, with the posterior approach, obviously we make an incision in the back. It's about 8 to 10 inches long. And you have to go through some muscles in order to get to the hip, called your external rotators. The muscles are detached, we put them back, but it's not as good as if we didn't attach them. And then in surgery, we take x-rays and we try to equalize our legs, which is a big deal. That's a big deal. When you do a surgery and you're left with a limb that is 3/4 inch difference. Now, that doesn't mean that if you do it this way, that's going to happen, but it can. Because for a number of different reasons, anterior hip can be a little bit more stable and you don't have to rely on leg length or the tension of a longer leg to give you stability. So on the anterior side, we go through the front, we go 3 or 4 inches, we go between muscle. So we make an incision here. Let me just show you my incision. So we make an incision like this. We split between the rectus femoris muscle and the tensor fascia, and we get down to the hip joint, and we do everything we need to do through that 3 or 4 inch incision. Okay? We know that dislocation rates are minimized. It's not a huge amount. It's not a huge amount. It's probably 3, 4, 5, 6%, but it exists. You can definitely get back to your activity sooner. I was driving in 4 days. I was back to work in about 2.5 weeks. Now I'm a different breed, okay? Not to say everyone's going to do this, but that's what I did. And from now on, that's what I'm going to push my patients to do because it's better. You got to get going. So I think you can return to all these activities. In fact, I'm unrestricted as far as what I want to do. So that's not really the end of the talk, but that's the last slide. But I think I'd like to open this up to questions because then we're going to probe into some areas that, you know, a lot of people here would really love to hear about. But truly, I think as far as the advantages of anterior hip replacement, I do think people probably have less pain. I want my patients off of pain medication probably after about 7 days so they can drive. Because depression is a big deal after joint replacement. People are around home, you know, and we want to get them out driving. We want to get them going. And so, you know, being mobile is a big deal. So if they can be off their narcotics in 7 days, for me, I was off at about 7 days, but I needed pain medication at nighttime for about a month. So I think people can get going. I think you can be without restriction, especially if you're a little younger and you want to do some of the things. I'm back doing yoga just as ineffectively as I was before. I'm swimming, I'm biking. I'm not catching any fish anymore, so I'm back to normal, okay? So I think it's a good procedure. It's really, that approach has been around for 40 years, but it's in vogue now because some of these components that we used to use, metal on metal, anterior, we used to do hip resurfacing. Okay, that was in vogue probably 5 to 10 years ago, but because it's metal on metal, it's out of vogue. So now this anterior hip approach is sort of in vogue right now, and it's pretty popular. So, how about questions? Any questions?
Do you do
Yes.
those?
I hope I don't make you mad, but you said you had your surgery done in Chicago.
Right. Why not here? Because I'm a Cub fan. No, because there's a little bit about having your surgery around here. The fellow that did it is taller than I am, and he played basketball at Princeton. That has nothing to do with it. But he also used a robot, which we here are thinking about doing also. And you say, well, what do you mean use a robot? And what that does is it makes sure that the components are put in a certain rotation. And we do this with preoperative CT scans. And you're going to see when we talk about total knee replacement, that's what we do. So you're going to see about that. So I chose that because it's away from Appleton. He's had experience with robotic anterior hip approach. That was the main thing. So that's why I chose this guy. Plus I went down and watched him, and then he was a good technician. But it's mostly because of the anterior approach. Next question.
I do a lot of lifting.
Yeah.
And I'm in and out of a truck about 50, 60 times a day. I'm right now shy for picking something up because I don't believe, I'm not confident in my leg feeling well. How long before I'm able to do?
The lifting and that sort of thing? You know, it depends. You know, I mean, you're going to be able to lift probably within the first 6 weeks, but it's a matter of how much you want to lift. You know, a lot of times we tell people after 3 months, you're going to be doing pretty well. Now, my guess is you're going to be doing pretty well even before that. Probably in anywhere from about 4 to 6 weeks, you're going to feel pretty good as far as getting around doing things. And my patients are all different, right? I have some people that are golfing in 4 weeks, right?
Driving or 7
Yeah, both. So it's variable. I mean, it depends on your pain tolerance, right? It depends on how tough you are. It depends on what you need to do. But I would say that probably after 6, 8 weeks, you're lifting almost normal. Almost normal. Doesn't it depend on your physical nature and how?
Well, or how good a shape are you
Oh,
in?
sure, absolutely.
Or to how long it takes.
There's a little of that. But I think that the most important thing, the question was, doesn't it matter on how physical you are? I think the most important thing that I've learned is that some people are tougher than others. That's it. That's it. It doesn't matter what age you are. You know, and so that's something that I can tell you you're going to do this in 10 days. You're going to drive in 10 days, and you may not drive in 10 days. But you are capable of doing that. 5 days? 5. You can go shopping, right, in 2 days. So some of this is variable. Now, if you look at the results maybe after a year, posterior, anterior, people say they're about the same. And so people may argue, well, why do you want to necessarily do anterior versus posterior? Well, it made a big difference to me. I was back working in 2.5 weeks, maybe as opposed to 6 weeks. That matters. You know, I can go swimming in a lake and I can climb up a ladder into a boat where my knees are really hyper flexed and my hips are flexed and my hip hasn't popped out. Not to say it would, but it hasn't for me, so that's good.
I've been told that there's more risks involved
With what?
with the anterior.
With a more risk? I'm not sure. And I'd have to say, what type of risk is there? You mean, in other words, whether the surgery goes well or not?
Because I asked a surgeon about that, and he said, well, there's more risks involved.
Well, I think you have to be careful. I think you have to ask a surgeon that does both procedures, and then he'll tell you if there's more risk. I mean, my guess is that if you have someone who doesn't do it, yeah, it's risky.
He does strictly hips and knees, too.
Yeah. I wouldn't say that. I wouldn't say that.
You wouldn't say it. Oh, that sounds good.
What else?
What if you have a fat pad?
What about if you have a fat?
Pad. Belly fat.
Oh, then we tape that up, throw it over your shoulder. But we do have to do some. Now, there's no question that body habitus has something to do with choosing anterior or posterior. I mean, we have people that are 400 pounds, and sometimes it's easier to do it posteriorly. And in that situation, there may be increased risk, and we choose to do it posteriorly. So I'm not going to say I'm going to take all comers. Initially I did, but we've chosen maybe heavier set people to do posteriorly.
So you do this surgery?
I do it.
How many have you done?
I've probably done maybe between 80 and 100.
Okay.
And it was the most difficult procedure that I ever learned because I did everything in the back. So I go to this course in Chicago, and they have a cadaver course. That's how we learn in orthopedics. And I came back from the course and I said, oh, that wasn't very good. I don't think I learned much. So how do you think I learned to do this?
Practice.
Practice? On you. On you. Any thoughts? How do you think I learned this? If you have to change the plumbing in your house, how do you learn how to do that, do you think?
Call plumber.
You just do it.
YouTube.
Seriously?
Now we have a website that's called Biomed, and that is like YouTube though. We have hundreds of orthopedic surgeons that are doing this. And I would go over and over and over and over and over it again. It is a fabulous way of learning. And there's nothing wrong with it. But that's how I would do it. And you know, the first time I did this live, it was wonderful. I said, wow, this isn't bad. But all of a sudden you get people that have different anatomy. And then you run into a little bit more of a problem. And then you say, well, how do we get out of that problem? You know? And so you go back to YouTube. So it was really interesting. But it was the most difficult procedure that I've ever learned in orthopedics. And now it's one of the more enjoyable ones because people really, truly do so well. If everything goes right, and it should go right, you know, it is very, very nice that they wake up, they don't have very much pain, they're walking, they're getting around beautifully. So it's a good procedure. What else?
10 days driving. You said 10 days before you could drive?
I drove in 4 days.
Well, I was going to say, is it medication related or is it just...
A little bit. When you're off your medication, you can do it. I mean, you have to feel comfortable, right? I was using crutches, but I thought, okay, I can get in a car. I can swing my leg. That's a tough thing. And then I drove. So, and I'm not trying to say 4 days. I'm just saying you can drive pretty quick.
How about a limp?
A limp?
Yeah. Does everybody, I know you can do the adjusting or the surgery with x-rays so you know where it is for like...
Right.
Is it pretty...
And that's a good point. When we do this anteriorly, you know, we're in a supine position, and then we can get an x-ray feel probably better than when we do this posterior, because we're up on the side. That's how we do the posterior part. And the other thing that's nice is we can do testing of the leg for stability. We are taking that leg and we're externally rotating, extending it, trying to make it dislocate, flexing it up, moving it around. And so it's a lot better testing to see if that hip is stable with an anterior approach. So, anything else?
You send your patients to rehab or not?
Yeah, we do. If you ask, did I go to rehab? No, I didn't. I mean, my contention was just do it. In other words, you get in the car, that's your rehab. I mean, you have to sit, you have to get out of the car, you have to move. Now, we do have people that go to rehab. I'd have to say 70% of the people go to rehab. But I started swimming right away. I started doing a lot of things that I usually do right away. So just like anything, it depends on your nature, your motivation, right? Some people, we don't need to have rehab. And a lot of people we do. So, what else? Oh, yes.
I just was wondering, I do need 2 hips replaced. Do you do 2 at once ever, or that's enough?
I think some people in the country, I've never seen it,
Okay, so it's
and I probably wouldn't
something you don't-
recommend it.
Okay. I'm
You
just
know,
always looking at how much time off of
Right.
work and,
but I mean, years ago, bilateral total knees, unheard of. I can remember there was a surgeon here in Appleton who did bilateral total knees. I mean, he just about got ostracized from the medical community for doing. Now we do this all the time. So who knows? But I mean,
so
I
could
think
you get one done and you're doing so well in 3 weeks, get the other one done?
probably not 3 weeks.
Okay.
I know I've done it with a couple people after 6 weeks,
Okay. You just, plan.
after 5 weeks, and that's a
Wanna
big
bring it
deal.
to the boss.
I was going to do it after a month.
okay. And you didn't.
Then I had another problem. I had to have my prostate taken out.
Oh.
So I had a lot of stuff going on. But I was planning on doing this
Okay.
after a month. So, what else?
Most insurance cover your procedure?
Yes. But I mean, we have very talented people that look at pre-authorization. That's an important thing. So we will make sure that everything is covered. But in general, the answer is yes. And in fact, it isn't, there's no additional charge. So it's not a more expensive procedure compared to a posterior approach. Same charge.
You said something about watching it,
Watching?
the procedure? Or did I miss
That I watch the procedure like on YouTube?
when you had it done?
I went down before the procedure to watch him operate.
Oh,
Okay, maybe a month before that, or a couple months.
well, I'm a high risk because of heart for anesthetic, so that's why
I mean,
I'm procrastinating.
Right. Typically what we do, then the question is anesthesia. That's another good point. We typically will put people to sleep or a spinal. We have a choice. If they've had surgery on their back, then we will put people to sleep. But spinals are great so that people aren't completely, asleep. They get up, they have good pain relief. And then we do a block called the fasciolatus block in here that takes care of the pain probably for 36 hours. In addition to our procedure is not a real painful one. For me, that is. For me.
Reduce your risk.
What's that?
Does that reduce the risk considerably for
Spinal
people
versus
with
general
heart
does. That's right.
problems?
Having a spinal versus a general is less risky.
And what about if you're on blood thinners?
Then we have to take you off a blood thinner. And sometimes we bridge you with something called Lovenox
Yeah.
and then get you back on your blood thinner. But it all depends on why you're on your blood thinner.
Because
Okay? Atrial fibrillation or,
yeah,
okay.
that too.
What else? What other questions? Yes?
We have covered this since I just walked in, but what's the typical lifespan of a new hip?
A new hip? I'd have to say it's between 15 and 20 years. The components that we use, the materials that we use now, are ceramic for the head, and then we use a cross-linked polyethylene that is zapped with vitamin E. That is our best material right now, and it's pretty good. So I'd have to say 20 years,
Okay, so going forward, I'm 40 years old,
right?
and 20 years from then, what's the, is there a risk for a second operation at some point? Is it more difficult? Is it impossible? Is it possible? I don't know.
Right. I mean, very typically, if you need a revision, it's because the plastic has worn out. And then your symptoms could be instability because the plastic now is thinner, you have more of a gap, you have more play, you have pain because these plastic particles are surrounding your hip joint now. There are millions of them. And so you're going to come in at 20 years and say, oh, I got this diffuse pain and it's getting worse every year. So in that situation, we look at your x-ray and we have to assess whether or not, and typically all we have to do is open things up, clean out all that plastic wear, and that's called a synovectomy, and then we replace the plastic. So it's very doable. We do this fairly frequently.
And if you're a really active person,
Yep.
will that decrease the life of the hip?
It'll decrease the life of the hip, right? Right. I mean, just because, think of it as you have just so many repetitions, right? I mean, when they test these things, right, they're putting it through repetition after repetition, and obviously you're trying to wear them out. So if you would say, I want to run marathons, I'd say you're crazy. But now, could you bike? Could you do other things? Could you do a lot of other things? Could you, you look at Bo Jackson, right? Everyone knows Bo Jackson, famous football player. He was a famous baseball player. He was stealing bases with a total hip replacement. But now he's gone through 3 or 4 of these things. And that's old polyethylene too. So we encourage people to be active, but we also want you to be smart about it. There are certain activities that are better for you than others. Yes?
Let's say I need a left one, because that's where the pain is at this point. If I get the left one, am I going to be overusing my right one then all of a sudden? Not all of a sudden, but say in a year or so, that my right one might?
Could. I mean, typically what happens to one side of your body happens to the other. Very, very typically. But I think what happens is you get one hip replacement, you feel even better on the other side for a while because you're unloading that side. So that's how it goes. But I would have to say 3, 4, 5 years from now, you may be doing this again. Could be. What else? Let's go on to knee replacement, okay? Yes?
Last one, can you run? I mean, I like play basketball, but I don't run playing basketball. Now I just...
This is what you do. You go over half court and you shoot, right? Okay, you can still do that. You don't have to go back and play defense. It's like the Grinnell. Has anyone seen Grinnell play? That's what it's like, right? You can be on the Grinnell team. All right, so let's do joint replacement. And so I entitled this, Getting the Most Out of 3D Imaging. Does everyone know what 3D imaging is? Okay. That is a possibility. Not a lot of people do this, but I think this is lights out. So let's just go through this. So here's a knee, and we have a patella, we have a femur, we have a tibia. And then we have these x-rays, and on this side it's supposed to illustrate normal x-rays. The way that we determine this is by looking at the joint spaces. This is the lateral joint space, this is the medial joint space. Most people have worn the medial side out, probably 80%, and they are bow-legged, right? Bow-legged. Now this one, this thing is completely worn out. On this side in particular, this space, you can't see that well, but let's just assume it's fairly good. So when 1 or 2 of the spaces wear out of 3, you need something to be done. And so we do this knee replacement, and really it's a resurfacing. Think of it as a tooth, that you need a cap on a tooth. So you have a cylindrical tooth with a cap being placed on it. And so what we do for the femur is we make cuts in such a way that this femoral component is placed right over the top of it. And you can do this either with cement, or you can do this press fit. We just pound it in, whack it in, okay? And the bone grows into it, okay? And on the tibial side, we've sort of learned, because of the anatomy, this is a flat surface, we typically cement these in. Some people in other parts of the country, they're also trying to press fit these in, and it's fairly good success. But around Wisconsin, we tend to cement. What I want you to focus on is this is called the lateral view of the knee. This is the AP view. Now, in order for success in knee replacement to occur, we want to make sure that our extension gap, so when the knee is in extension, is equal to the flexion gap. And not everyone was paying attention to this for many, many years. But so this is what we're talking about. We have a knee replacement that the plastic is here. And let's say it's about 1/2 inch. Now we flex our knee, and it better be 1/2 inch. Otherwise, if it's more than that, we have a lot of instability. Okay? And we have a lot of wear and tear. Now let's just make believe that we put this knee not like this where it's symmetric, medial, But let's say it's about like this, so that it wears in a single point. It's going to be worn out very, very rapidly. So we need to have good stability in flexion and extension. And so when we make our cuts, we want to make sure that this is equal to this. That will give you success. When I describe this to my patients, we used to say 86% of the patients love their knee. They really did. But 14% didn't. That's a big number. You know, and a lot of this has to do with balancing the knee. That's what we call it, balancing the knee. So, I used to use a computer for about for about 10 years. And then this other system came into effect, and I'm going to just, if I can have this, thank you. So this is what we do. And again, not very many people in the Valley do this. I'm a little surprised because I love this. And so we get a preoperative MRI scan. And what we do is that we scan your hip joint and we scan your ankle joint and we find the center. And we draw a line between the two. And that's called our mechanical axis. Then we scan your knee and we get a 3D mold of your knee. Okay? We have this. And because of the mechanical axis, they will then make the tibial cut perpendicular to it. And then all other cuts are going to be based off of that, in addition to the posterior condyle cut, the anterior, the distal, so that our extension gap is equal to our flexion gap. So this is so cool. You get an MRI scan. The scan goes to Brussels. That's where they do this for this company, or maybe even up to Canada. They bring us this back in a month with a cutting jig that goes on this thing, and it fits like this. At surgery, I get this. I take this and I snap it on your knee. And I drill these holes, and I make all my cuts. It takes me 23 minutes. Isn't this amazing? So I'll pass this around. Now don't put it in your purse. Jeepers.
So is the bottom part your actual, the top of your leg?
Say that again.
Is the bottom part, this part of your,
So in other words, we have the femur, which is the top part of the knee, and the tibia,
Right.
which is the bottom part.
so is that bigger part the tibia?
That's the femur, and this is the tibia. So we do exactly the same thing on both sides. Okay? So we make these cuts, and then I have to use my brain a little bit. But not that much. Not that much. I don't have that big a brain. So to me, it is such neat technology. What we used to do, remember I told you about this guy that did it freelance? And he was pretty good back in his day. But if we look at the femur bone, the way that it is done now, and again, I'm not going to try to badmouth anything. I used to do it this way. But we used to put an intramedullary rod up the femur, and your femur is trumpet shaped, right? It's hollow. If your bones weren't hollow, you'd weigh about 800 pounds. You got that? It's trumpet shaped, but can you imagine where your entry area is? And can it go off on this angle? Could it go 3 degrees this way, right? I mean, it's not wrong, but there's more room for error. So if I take a rod and put it up like this versus like this, and I do the same thing on this side, this versus this, there is a little room for error. But the way that we do this, I think it's pretty good. So when I tell people about this 86%, I don't know. I don't think that's right anymore. I mean, the people that have these replacements, they should be really, really, really satisfied. I mean, this should be close to 100%er. It really should be. I mean, and that's been my experience.
Can you kneel on it? And how long will the knee?
Not every knee can you kneel on. The knees that I use, I mean, it just happens to be, I tell people to kneel on it. I used to do a different knee, and I told them, yeah, try kneeling. And say, I can't do it. But some of them, they can. It depends on how we prepare the patella. And so I tell people after 6 months, you can try to, kneel on it. And people do kneel on it. No question about it. They break their kneecap, but we can fix that.
Depends if the knee bends.
Yeah, but we should be able to. Now, what we want happening, a normal knee has 140 degrees of bend. We want at least 125. So we're really pushing, and I'd have to say the majority of the time we get that. Now, if we don't balance our knee, we will run into problems with knees that don't bend very well. And they may only get to be 90 degrees, 100 degrees. But 125 is something that we push for. And I think that we get it most of the time. And that's a big deal. 10 degrees off. In order to climb stairs, we have to be at about 90 degrees. In order to go around on a bicycle, we have to get up to about 105, 110 degrees. And so every degree is important. And we have people that are 130 degrees.
How long before you should be able to do basically what you did before the surgery? Normal.
I'd say it's about 3 to 6 months. But I mean, I think you're really, really active right away. Again, we have people that are golfing in 6 weeks. Are they playing 18 holes? Are they walking 18? No, probably not. But I mean, I think they're pretty active. I would say swimming, in 6 to 8 weeks. I would say working on elliptical, an exercise bike, probably 4 to 6 weeks. Driving, going out to eat, all you can eat, you could do that probably in 3 to 4 weeks.
So if you have a knee that looks like it's worn just on part of it, do you do just a partial knee, or will you do the whole knee, since 9 chances out of 10, I would think, I don't know, but I would think that the other side's going to wear out in no time at all anyhow.
Partial knee replacement is a wonderful procedure. And what we're talking about is that if we just had, let's just say, in this situation, we just had wear here. Our kneecap view looked pretty good. We do partial knee replacements, and the company that we deal with makes these 3D images for knee replacement. And it's wonderful because, again, it all has to do with alignment. Longevity of these components have to deal with placement and what cuts you make. And that's a big deal. So to answer your question, we do have knee replacements. It's a great procedure. It's a wonderful procedure. Can the other side wear out? Yes. And I've had it happen. I think since these 3D images, though, it is near perfect. And you don't overstuff. That's what it's called, overstuff one side. You put too big a spacer on one side, and now you overload the other side, and that patient wears out. And that's another advantage of doing it this way.
What's the recovery time?
A partial knee? Oh, maybe half the time. It's pretty quick. Very quick. Even for you.
Are there options
Options?
to anesthetic with knee replacement? I've got a bad hip and 2 bad knees.
Right. Are there options to anesthesia? There are a lot of options. And the options go like this. If your cardiologist said it's better to do a spinal, then we do a spinal. Then we have all these blocks that we can use. Total knee replacement, total hip replacement is relatively, I'm not going to say pain-free, but it's pretty good these days. We have things like femoral nerve blocks, where we numb up the leg for a period of a day so you have no pain. We have topical injections called Exparel that last for 36 hours that make it nice. We have drugs that are called Toradol, which is fabulous.
So
We-
you
we-
wouldn't necessarily have to be put out.
No, definitely not. We also want to stay away from narcotics. Narcotics cause problems. They're great for pain, right? They're great. But they cause constipation, urinary retention, make you wacko, more wacko.
Feeling he's picking on you.
Only because I love you.
Well, okay.
Replacement take, like if you chose a spinal, how long do you have to sit and listen to all the stuff going on and the saws and the drills and?
You know, probably about an hour and 15 minutes.
Okay.
About. And really, I don't think you're going to be listening to that stuff.
Well,
I
I
mean-
don't know, I had C-sections and I
Okay.
always listen and,
Yeah. Did you agree or disagree with what they were saying?
well, you're just, yeah, you're excited and
Yeah, you
whatever,
are. But I mean, I think they give you
but
drugs.
you don't feel anything.
Yeah.
I
They,
just feel them moving.
I mean, they should give you drugs so that you don't comprehend what's going on. They
Okay.
really should.
And I'm sure they gave
Yeah.
me something to relax. I don't remember that,
Right.
it was a long time ago, but, yeah, so really.
I mean, you
spinals
shouldn't-
and-
Did you have a spinal? Yeah.
No, I don't think so. No,
Were you put to sleep?
for my shoulder,
Yeah.
yes.
Okay. Because we give blocks for shoulders too, but we also, in shoulders, we usually with the shoulders, we put people to sleep. There are some situations that we don't. And again, you know, people really don't comprehend what's going on.
So maybe that's the better alternative.
Could be. It's a little bit up to you. But again, we've done this so many times that we recommend spinals because you don't have this mental effect from it.
Yeah,
You know, there's, whether it's loss of brain cells or something.
Dr. Eggert,
Yeah.
when do you know that you're ready for knee replacement?
When I tell you, Walter, when I tell you you're ready,
My knee over there?
that is your knee, Walter. But you are you're one of the toughest guys I know. Walter came in and he gave me his hat, his Marine hat, because he was in the Marines. But Walter is tough. You know, he is a instructor for skiing, and he has a knee that I'd say, how do you even stand on it? Much less ski, right? So, I mean,
It doesn't hurt skiing, it hurts teaching.
but I don't know. I mean, some people can just, they can just go on and on and on, and I just go, wow, how does that work? But they do, and that's great. But I think you'll figure out when enough is enough. I know I did.
Is there an advantage to doing both of them at the same time?
Is there an advantage?
Well, okay.
Well, yeah,
Is it a
there
good
is,
idea?
right?
Yeah.
I mean, there's an advantage that you are over it pretty rapidly.
Is the recovery different?
This is how I approach it. I don't tell people if they have two bad knees to do two bad knees. If they ask me, Dr. Eggert, would you do two bad knees at one time? I say, sure. I want you to bring it up because you are a special person then. Truthfully, people that are kind of wimpy aren't going to bring this up. The people that have bilateral knees do fabulous. They really do. In fact, they probably do better than because they are so tough. They come in, and I can tell you, they come in 2 to 3 to 4 weeks, and they're walking around pretty darn good. And I can think of a lot of the bilateral knees. So the answer is yes. And do you have to go through it twice? Obviously not. You don't have to have general anesthesia twice. So, I mean, there are advantages. You get it over with. But and I can tell you're a tough person.
I am.
I know. You're stubborn too. So what else? What else?
Do you get a buy one, get one free if you
You're not supposed to bring that up.
Well,
At least a reduction.
thinner you are, the easier it is, right?
The thinner you are, the easier it is. Yeah, I mean, to some degree. I mean, some people, their body habitus is that around their belly, they're big, but their knees are not big, so that's not hard. So yes, if you have huge knees, then it would be a little bit harder, but I mean, we do this all the time. It's tougher on my assistants, right? It's tougher on my assistants to do this because it's hard to hold. But can you do this? We do this all the time. I mean, we would love to have people that are a little bit more petite. But that's not the reality of it, right? We've talked about this, right? How do you exercise if you can't walk? It's easy for your spouse to say, get out there and walk. But how do you do it? It's tough.
You can't.
Yes?
The difference between titanium knee and a metal knee?
Titanium has been a buzzword probably for 15 to 20 years. And it's been around forever. Titanium we use for hips because it's a relatively soft metal. They've tried it on knees and it's too soft. So we don't use it. We really don't use it. There are some companies that use ceramic for their knees, but typically it's really the plastic that's important in total knee replacement. And everyone is up to speed on this. Everyone has the most updated plastic. Unless you're Medicare, then we give you a lower bid. No, but we give you, is that right, Josh? We give you the cross-link poly.
Correct, yeah. The metal is a cobalt chrome, it's
Right.
an alloy.
Right.
But the poly is a highly cross-linked vitamin E infused poly.
Right.
Top of the line.
Yep. And the fellow behind the barrier is my representative from Zimmer/Biomed because they were, but he has been wonderful and he's an engineer and so he helps us. You know, in other words, when we did this 3D thing, you have to plan for this and so he does all the planning. In other words, how do you get all these gaps the right way? So he's been fabulous as far as doing that stuff.
So you come to see you and you need your total knee replaced.
Yeah.
So you go through all the MRI.
Right.
And then it takes a month to get this back. and
Right.
so then
Right.
surgery's after.
Unless you bring in cookies to Josh. And then you get it done in a week. That's how this works. But it's about a month.
A month.
Yeah.
okay. And hospital stay for a total knee?
I mean, let's go over this. A lot of people don't understand our medical care. I mean, this is complicated. If you are 65 and older, okay, you are a secondary, no. You are then considered Medicare, right? Not always, but let's just say that in general. If you are less, we call that commercial. You're a commercial payer because you have commercial insurance. Now, by law, if you are Medicare, you have to be done in a hospital. That is going to start to change. And surgery centers like ours are going to be allowed to do this. But right now, if you're 67, you have to go to the hospital. And then depending on if you're going to go home. If you go home, you have to stay about 2 days. Or you could go home in 1 day. If you want to go to a skilled nursing facility like our Recovery Inn, then you have to stay 3 days. I mean, these are Medicare rules. If
You
you,
have to stay 3 days in the hospital?
correct, correct. So now if you are 65 and less, we do surgeries here. We've done 1,000 of these total knees and hips. And you stay at our Recovery Inn for 3 days. And we wine and dine you. But it is really a fabulous facility. Better than anywhere else in the country. It really is. I mean, we've researched this. This is 4 years old, our Recovery Inn. It is fabulous. Yes, sir.
If you're tough, can you leave the same day?
Yeah, absolutely.
So do you need the recovery center?
Um,
Well, I know you need it, but
I think typically what we would do is we would watch you. The answer is you can go home the same day. You could, if you were prepped for it. Typically what happens is you stay overnight, you go home the next day.
makes sense.
So, yes.
What's the lifespan of the 3D knee?
What's the lifespan?
Yeah.
You know, again, I would say because we're so good at the way that the metal hits the plastic. There's so much surface area that is putting pressure on the metal as opposed to just one spot. So I think the longevity, I think we're going to see knees that are going 20, 25 years. I mean, that's what now, the same holds true for this. Let's say that it wears out. Then we can, because this is a modular prosthesis, it's not all one component. We change your tire. We snap out the plastic, we put in a new one. You're on your way again. So it's much different than having to do everything over again. Right?
After you have the surgery, do you have to walk every day?
Do you have to walk every day? The hip or the knee or both? The knee? I mean, we would encourage you.
Like 1 mile?
I mean, if you're driven by food, we would dangle food in front of you to make you walk.
That would do it.
Because walking is good. That's why we're doing this procedure.
I do walk, but he doesn't like to walk.
We'll make you walk because that's why we're doing this. I mean, it's not like walk a mile because you go backwards too quickly because you swell up. Little walks are good.
How about walking on the treadmill?
Walking on a treadmill is good. Mhm. We want you to do all that. Yes, sir.
If you have knee surgery, do you come here for rehab work or exercise work, or do you go do it on your own?
You go someplace that you want to go. This is patient driven. So in other words, if you had a physical therapy place that you wanted to go, that's where I would recommend you go. I mean, we have fabulous therapists here. So depending how motivated you are, usually this is what I do for knees. You're in the hospital, the next week you come back and you are here at Advanced Physical Therapy, probably for a month. Knees are different than hips. We need to get your range of motion. It's a tougher thing. We got to push you a little bit. Hips, we just got to walk. We got to get your strength back.
That's why I thought that maybe because you had it done here, you'd want them to come back here because you could watch the procedure and how you progress.
Again, I think there's an advantage of coming here because people understand what we do. Yes?
I forgot. Oh, I know exercise is good, but is swimming and biking, is that kind of like wearing on the knee?
Think of it this way. You know, if you do non-weight bearing activities and you would say swimming, biking is a little bit weight bearing, right? Because you're putting a little pressure. Running is weight bearing. So there's a continuum here. So, I mean, it would be nice to swim, but if you don't swim and you're going to drown, that's no sense swimming, right? So, I mean, there are activities that are better than others. And we always talk about elliptical. I love elliptical. And I tell people elliptical as we're going through this. But are there people that run? Does anyone remember the name John Paulus? John Paulus? Who's John Paulus? For who? Yeah, he used to be the Badger coach, right? Many years ago. I think I don't know when he coached. But if you've read in the papers recently, he's now 84 years old. He has bilateral total knees, and he has won the seniors at Wimbledon, I don't know how many years ago, in his age group. But I mean, can you do this? Sure. But I mean, everything is relative, right? Do you want to do that sort of stuff? If it really makes you feel good about it, well, then maybe you do something like that. What's that?
I said,
No.
Been there, done that.
So, I mean, you can be active. You hear of people running with this. But, I mean, that's not why we're doing this. This is pain control. This is moderation. That's what we want. But we also can do a lot of good things to make young people feel challenged. Sweat. There are a lot of things you can do. Hold it. Right here. Pardon me?
Stairs,
Stairs?
the hip replacement, is it
If you want to get up to your bedroom, it is. Yeah, I mean, you do one at a time. All I can tell you what I did, I had 2 crutches. I did 1 crutch at a time, and then the first night when I got home, I went up to bed. The one thing that is a tough thing is getting in and out of bed and lifting that leg. That's a toughie. But eventually, after a couple, 10 days, then it's okay. Yes?
The name of that shot that you can get instead of an
Exparel.
okay, how do you spell that?
Exparel. It's a topical anesthetic. Everyone's gone to the dentist and you get lidocaine or xylocaine and it lasts for 4 or 5 hours. This is a little bit special and it lasts a little longer. And it works, in my mind, a little bit better. You know, again, we have all these things that are, none of it is perfect, but it's sure better than 20 years ago when we did this. You know, we would zap you with morphine, you would be out of you would be out of it for 3 or 4 days. You didn't even know where you were, right? So we do things a little differently.